Hello everybody, I am Lars E. Olsson, Professor of Medical Physics at Lund University, and my webinar will be on how to convert from a combined CT MRI workflow to an MRI-only workflow of treating prostate cancer with radiotherapy. I will use this outline throughout the presentation. It was originally made by my former PhD student Emilia Persson for presenting her thesis. So it divides the workflow into certain steps and addresses different tasks that needs to be carried out when you go from a combined to an MR-only radiotherapy workflow. And I will go through these steps one by one. But first, a few words about the motivation. In the dual modality workflow, we use both CT and MR images for the treatment planning. These images are acquired at two different examinations, and the geometry will be different. We will outline the target organ at risk at the MR images, but then we need to transfer that information to the CT frame of reference because that is what is used for the treatment planning and the treatment itself. This process creates an unnecessary geometrical uncertainty. In the MR-only workflow, we don't have the CT. We do have the same MR images, but we will add an additional sequence to acquire a large field of view MR image covering the outer surface of the patient. And that one will be used to generate a synthetic CT. We can outline and contour on the MR image. We don't need to transfer that information to the CT, and it will be in the same geometry as the synthetic CT, and we use the Spectronic software MRI planner to generate our synthetic CT images. The principle of synthetic CT is that you use MRI images to produce synthetic CT. In this case, there is a CT of the same patient for comparison. A few years back, we did a large multi-center study with more than 100 patients to validate the MRI planner software. There was very small dose differences between what was calculated on synthetic CT compared to CT. The main differences found was actually due to that there are some patient positioning differences between the CT and the SCT. Recently, we have also started with synthetic CT of the skull in collaboration with Spectronic, and you can see one example here where actually the effects of surgery is quite evident, and the synthetic CT is depicting that area very nicely. So when we now do the MR examination and we acquire the image that's going to be used for the synthetic CT, it's really important that the settings of the sequence are correct and the same every time we generate data to obtain the synthetic CT. So therefore we have generated a script on the GE MR scanner, so it automatically checks the parameters used for the MR acquisition, and a notification is sent and can be checked and approved that the MR parameters are indeed correct. And then when it's done, the volume, the large field of view volume is exported to the MRI planner, and the MRI planner gives us back the synthetic CT. We export the MR volumes to a DICOM node, and the MR volumes is then imported to the treatment planning system, and when the synthetic CT is done, it's also imported to the treatment planning system. Since we are now in male pelvis treating prostate cancer, I need to talk a little bit about the identification of the gold fiducial markers. So in CT, markers are quite clearly seen because they are metal, and the radiation is attenuated quite clearly here, and you can see the marker here, and also a calcification which looks different than the marker. In MRI it's different. The marker and the calcifications create a single void which can be hard to identify on the images, and therefore we have worked with different sequences and came and ended with a multi-echo gradient sequence where the initial echoes shown here, the voids are quite small, while on the later echoes the voids are quite big. And by studying this pattern, you can actually easily define the fiducial markers, but you can also differentiate the markers from the calcifications. In the studies, we always identified the markers manually, and we still do that in the clinical routine application. However, we have also worked on automatic identification, lately using artificial intelligence. Even though these methods may not have a 100% success rate, they can be used as for decision support and can be quite handy. So the position of the markers are determined in the large field of view image, and the coordinates are exported to the MRI planner, which burns in the coordinate in the synthetic CT volume. And you can see how the positions of the marker looks when they are burnt in, and also visualized in the DRR from the synthetic CT. Target and organ at risk delineation. We need to talk a little bit about that. Now we're only using MR images. It is very well known that the volumes will be different if the contouring is performed on MRI or performed on CT, and it will always be larger on the CT, between 1.2 to 1.5 times. However, this is not a fair comparison to the case going from multimodality to MR only, because in the studies to the left they only used MRI or only used CT, but in a dual modality workflow you actually use MRI but register the information to the CT. So will the volume still be changing? And we couldn't find that much information on that, so we did a study of our own, and we found that the volume still was larger using the dual modality workflow compared to MRI only. And we think that the reason for that is that doing the contouring, the oncologist is actually using both the CT information and the MR information in the combined workflow, and the volume will then be larger, in our case 20%, because there is some misalignment in the image registration, and there's also difference in the anatomy. So to be really sure, one have to contour a little bit larger, because the treatment is given in the CT frame of reference. So any clinic who should start the MRI-only radiotherapy should probably review their processes for how they outline or contour the target and target and risk, and see if there will be any major effects of changing workflow. So for the treatment planning, then there are some extra tasks to perform on the MR-only workflow. So the synthetic CT volume is visually compared to the MR volume to see that everything makes sense. The marker positions in the synthetic CT is verified and validated against the MR volume to see that that makes sense. The counts by itself doesn't present any MR signal, so that is lacking in the image. So we need to account for that and change the setting to 1.5 centimeters below body. And we also create the DRRs from the synthetic CT volume. So when we did a study on MRI-only implementation, we used a CT in the background. And the way it's used is that before we press the radiation button for the first fraction, we actually check that everything's done with the MRI-only can be verified and be as good as if we were using CT. So what can be done if you have the CT is to verify the markers and see that they are correct in the DRRs. One can compare the Hounsfield units in the CT and synthetic CT, and one can also recalculate the plans to see that everything is okay. And having done that, the MRI-only treatment can be approved. So this is of course only in a study, or maybe if you are going just to implement MR-only workflow in your own clinic, it's probably good advice that the 10 first patients are doing CT in the background, so you can check that all procedures are correct. Because once you go into clinical routine, there will be no CT data available, so it's better to check beforehand. But you can do one thing which is similar even in clinical routine, and that's to use the CBCT data acquired at the first fraction. Obviously, it cannot be acquired before that, but it's still very useful and good check for geometry, Hounsfield units, and those calculations if you want to. And that is quality assurance that can be done once or several times if you want to for the same patient. So what I've been talking about and a little bit more obviously can be found in the thesis written by Emilia Persson, and you can also download them freely using the link or the QR code. I just want to end with acknowledgement to all my colleagues in the research group, and thank you for their great work that have made it possible to use MR-only radiotherapy in pelvis and now also in the skull. And also a great thank you to Spectronical Medical and GE Healthcare for the great collaboration during this process. Thank you.